Dr. Am, for bestowing this honor on me to be sharing platform with one of the field giants who is second to none in addressing any topic, be it artificial intelligence or natural intelligence or any topic on our field. You may not have noticed, but Professor Abulgar finished the last slide exactly at the end of time allocated. This is a sign of a lot of attributes: respect, consistency, quality, role model, name it. So to be sharing platform with Professor Abulgar, I find it is honoring me because who I am. Probably after I listened to Dr. Abulgar, I felt even more proud because I felt that I may qualify to be one of his students, because everything of what he said has resonance with how AI should be seen. Despite me being an ordinary person, and despite Professor Abulgar, I can honestly, it's not a compliment, it's not a pleasantry. He is one of a kind, and there is only one Muhammad Abulgar. Now, debates are about yes or no. Someone saying yes, some saying no. I'm sorry to disappoint you. It is not like that in this session. Why? Because we are all in this together. We have stakes on using technology, but using it with sense of responsibility and accountability and using it in the relevant way and protecting ourselves and our patient against the drawbacks of any advance in medicine where the hype and the exploitation. But even if I appear to be taking a different angle or point of view in any of what I say, I would refer to Gandhi when he said, honest disagreement is often a good sign of progress. But I can assure you there will be no disagreement. Now, one of our own, where is Dr. Raouf Rushdi? تاخد غياب, and I will not promote his book. Is he here? No. He really has got that extreme interest in AI, and he is producing a lot of literature and explain what is involved, and it is nice to be conversant with what is going in the world, and really he's doing a great job. The motion talk about revolutionizing, which in the dictionary it says change something radically or fundamentally. If we apply this to our field of reproductive medicine, we need to answer a lot of questions whether that term revolutionize is appropriate or otherwise. Revolution is a rapid, fundamental transformation of a field. So obviously, AI probably is running slow because we have not seen that change yet, despite the reference that Professor Abulgar made that AI has been around in one shape or form since 1956. It has gathered pace over the last few years, though. What is the outcome of this revolution? Revolutionizing the means, which is how we do things, or revolutionizing the end, which is the outcome of the treatment? Because my focus is only on assisted conception and using AI in infertility. Which one it will revolutionize? Because it will revolutionize the means, nobody would disagree. We could do things faster, we can do things smarter, we can do this and that, the other. But will it alter the almost monopoly of biology on the outcome of the treatment that we do? That is the question that we need to ask ourselves. What do we have so far in the literature is promises. And we hope that they will deliver, because you will see things like this: AI in gamete selection, AI in embryo selection, AI in treatment regimes. AI can or could complement current clinical practices while it's offering objective gamete selection to substantiate the assessment made by the embryologist. I feel that this is a flowery language and it's almost persuasive, but I don't think the embryologists have complaints. And for the majority of patients, any well-trained embryologist will make that selection. So it's important, maybe it will have a place in sperm selection when you are doing TISA for non-obstructive azoospermia. Certainly it will have a role, but at what expense? Also, embryo selection, and unfortunately, we don't appreciate that probably even in those patients who have pre-implantation genetic for aneuploidy from a large database in the United States, 40% have a maximum of 2+ success. So choice is not really be all or end all, although it is where the money is made. So AI is integrated across the ART pipeline in the diagnosis, and people talk about predictive models, infertility risk stratification and patient triaging, stimulation, FSH dosing optimization, cycle outcome prediction, ovarian response models. Again, we need to be really very careful because the devil is always in the details. It's big words. But for any decent clinician who has done his homework, choosing the right regime for the right patient is not rocket science. I am not welcoming any extra we get from AI, but it must be questioned at what expense, because I am focused on money, unfortunately. Fertilization, sperm selection algorithm, oocyte morphological analysis, and XC automation. Science also, all 60 words. Who wouldn't like to be in the 21st century? But what the added value? How practical? Has this been validated? Because without validation, it becomes a could or should. And most of the literature will have could or should. And you know, in the English literature, when we use could or should or would, we are less than 50% certain. So it's important to bear in mind that context. I am against aggressive marketing for anything. And aggressive marketing is starting, sadly, for AI. And some places are using, just because they have access to an AI machine or they use AI in a certain part of their practice, is hitting the news so that they can charge the patient a little bit higher. And the media talk about elevate your IVF consultations. Success Predictor leverages AI to create personalized report for each patient, helping you set realistic expectation and boosting confidence in their treatment decision. If this is being validated, I will have it for my patient with open arms. But the validation is not there. And ask, book 20-minute personalized demo and get set up with a free trial account, no strings attached. The strings will come later. And look at what they claim. You will have 44% with one IVF cycle, 79% with two IVF cycle, and by 3 cycle is 92, which is not totally exaggerated, but nonetheless, we need to see the data that underpins those predictions. How about the media and the AR professionals? What kind of combination do you think? Sadly, this is a match made in hell. Because people will exploit this, they will have advertisement, they will have promotion, they will have this. If it is done the decent and the honest way, nobody will have. And we have previous experience, and Professor Abagar mentioned that we have seen things before, and we need to take lessons from the past. Here is the embryoscope. It describes use of time-lapse imaging to spot embryos at high risk of genetic abnormality. Then supposedly, if that was true, and this work is in 2014, we're talking about 11, 12 years. Then if that was true, PGTA would have been done and dusted. If the embryoscope will discover what is chromosomally normal and what is chromosomally not, we should not have it. So that bit of time lapse and monitoring of growth, like you see in these images, has not been found enough to substitute the need in some quarter for PGTA. Look at the publicity. The Times newspaper, which is a solid paper, covered the story when the AI was introduced, when the time lapse was introduced. It said a new IVF technique that could give 78% chances of success. Did it? I stand corrected. Has that made the difference? It hasn't. And some very significant embryologists and scientists said, in the 35 years I have been in this field, this is probably the most exciting and significant development. Don't want to waste your time, but in Scandinavia, they did a randomized controlled trial of time lapse versus time lapse. Absolutely no difference in the outcome. So history seemed to be repeating itself. It's good to focus on the areas that is the major strengths, the diagnostics. But when it comes to therapeutic and when it comes to biology, we have to proceed with caution. This is a clinic in London. Very aggressive in marketing artificial intelligence. It's a good clinic and they are good people. I'm not claiming, people have different emphasis. Reproductive intelligence review, you have a consultation, you have a 3D ultrasound with artificial intelligence, you have semen intelligence, you have egg intelligence, you have embryo intelligence, and the list goes on. Some people are on my side, perhaps, saying that AI setting unrealistic expectation. And people need to appreciate that it is not a magic bullet. There are lots of reports in the literature which talk about different varieties of AI and claiming that 75% clinical pregnancy prediction accuracy, 92 implantation accuracy, 77 clinical pregnancy rate, matches manual outcome in one series. It was not different from manual selection. And 51 biochemical pregnancy rate for optimal embryos. We get that without artificial intelligence. And the list goes on. Now, don't waste your time. But here is an example of marketing. This is a very decent clinic in France. Talking about the American Hospital of Paris revolutionizes assisted reproductive technology with AI. By using AI, or AIVF as they call it, is radically transforming outcomes in assisted reproductive technology with a considerable impact on patients. The average number of cycles needed to conceive has fallen by 53% from 3.4 cycles with traditional method to less than half of this, 1.6 using IVF. I would welcome this with open arms if that was a result of objective study that was peer-reviewed and published in a decent journal. It just doesn't exist. So we need the proof for those claims in order for us to advise our patient and perhaps justify them paying the extra. There is a systematic review that Basil Wattar, who will be with us in the Upper Egypt meeting later in late January, looked at studies on AI, and his conclusion was no evidence of improved outcomes. And that does not really and should not surprise because biology is finite. Artificial expectations, time to get real about AI. These are voices that are shared in the media. So why AI is bad? We need to understand the risks, the limitations, and the consequences of AI because the wrong assessment can lead to the wrong intervention. Plus, there are inherent issues about AI. Most clinics are too small and in isolation to have sufficient data to exploit AI. So that is creating the haves and the have-nots, which is not good for humanity. Limited computer power and data storage, discrepancy in recorded and reported patient characteristics, variation between studies in the input parameter used for AI. Of course, there are requirements to develop AI. We're not saying just kill it off. Consortia to develop standardized and detailed recording and reporting, like Professor Bulgar was referring to, you couldn't send the data to other center because there is no harmony in terms or harmonization of practice. Multi-clinic sharing of anonymized data and rigorous, high-quality, multi-center peer-reviewed validation of those algorithms. Human skills like judgment, creativity, and ethics remain at the core of medical practice. They are unlikely to be replaced by AI anytime soon. And it will be a sad day when if that happens. So what is the golden rule for AI? AI is a tool, and like any other tool, it should follow the golden rule. All tools must enhance, never erode your most important one, your mind. We can't give up on our intelligence. We can't give up on our responsibility to exercise judgment. We can use it alongside AI, but we cannot just throw the towel. Be curious about AI, but also examine how it shapes your habits and your thinking patterns. Stick to that rule and you will have nothing to fear. If we approach it with the diligence and the due diligence that it requires, we will not be fooled. There are expectations and there are realities. Of course, expectations are usually proportionate to disappointment. If you have high expectations, you are almost certain to be disappointed. How we measure the expectations? We see those publications, artificial intelligence-based donor oocyte quality assessment, moderately improved prediction. Those oocytes are naturally of good quality because donors will be handpicked for age and for AMH. Look here, the area under the curve is 0.6, which means you are as close as you can get to just tossing a coin. Either it is up or down. Here is AI feels like an unstoppable force, no doubt. It's going whether we like it or not, but it is not a panacea for business or for society. In dabbling with artificial intelligence, humans seem to have taken on the role of Prometheus, who apparently gifting machines the fire to spark civilization. That's one of the Greek gods. Columbia University was also talking about the precaution ethically. Would you want to know if Alzheimer were in your future? Because AI might be able to give you that information. We do PGT for Huntington disease, which is adult onset disease. So many patients who would like non-disclosure, they don't want to know whether they are or they aren't because they don't want to live the rest of their life in turmoil. They are just doing it to exclude the embryos that may have the condition. AI's integration into IVF holds promise, no question. Everything that Professor Abougar said is true, and we have to look forward to that for advancing patient care, but its clinical potential requires careful evaluation and ongoing refinement. The challenges faced in IVF involve usually complex biological, medical, and technical factors. Which model will talk to you about a patient whose AMH is 2 and she has adenomyosis, and in the process she had hysteroscopic resection of her endometrium, and she's undergoing treatment? You need more than this AI, because really, who is the surgeon, what happens, partial, complete, the kind of adhesion extent, we must retain clinical judgment based on the clinical scenario. People try to question human brain versus AI. What makes better decision? I think that question is open up till now. Artificial intelligence versus the human brain. These are the questions that are. But then when we talk money, because this is the important too. People who invest on AI, which is expensive, and particularly automation, I am sure they have in mind to get back what's called return on investment, which is perfectly reasonable in business. But have you considered applying the same principle with patient? What you get from the patient, are you giving her return on investment? She will pay money. What is the added value that you will give the patient in return for that investment? I had to cover this very young lady because it's not good for health or for this platform. But you can see a picture of a patient who's surrounded by money. She is covered by money all over. Those are fantasies. The patient that we deal with, even in London, they either have finished their resources, having tried 2 or 3 times, and they don't have more money. Even when they borrow from the bank can give them no more. The human brain excels in contextual understanding, the context, the feeling, the emotional intelligence, and creativity, while AI offers unparalleled speed and precision in processing data, as Professor Abougar mentioned, and performing specific tasks. There isn't a single better option, as they are fundamentally different and often complement each other. While AI excels in data-driven optimization, risk assessment, and operational efficiency, no question, it struggles when dealing with ethics, strategic foresight, and unpredictability. While AI holds immense promise for enhancing IVF efficiency, standardization, as again mentioned by my professor, and outcomes, its current trajectory reveals significant challenges, as they've been highlighted. When you ask fertility patients about their perception of artificial intelligence, large section in the last, they say it means that you pay more for medical care that is informed by AI. So it's already the seeds have been sown that AI is expensive, prepare yourself to pay more. One plea, please don't confuse the end with the means. A patient who's 44 will always have the reproductive performance of a 44-year-old. Whether it is AI or IA, biology will not be that flexible. We may make the patient better informed by sharing data with her, but we are not likely to change. We need to be innovative so we can better deliver on the needs of our customers. And the ethics of artificial intelligence in embryo assessment mapping is also being questioned. And while artificial intelligence may offer clinical benefit for embryo assessment, its successful implantation require awareness of the ethical issues. And there are so many ethical issues that are being raised and ethical implication. Their place is not here, but I just wanted to share some of you. Dehumanization, accountability, transparency, bias, descaling, access, all of that is AI will not have a conscience. We demonize people when we say they don't have conscience. فلان ما عندوش ضمير. AI ما عندوش ضمير برضه. Okay, so it is important to remember that. Your moral conscience and ethical decision making of yes or no cannot be done for you by AI. Artificial intelligence won't improve poor IVF practice. If you are poor at what you do, if you are doing IVF in NASA, your outcome will be poor. And one thing more that has been mentioned, we have been using patients as guinea pigs for a long, long time. We use them as guinea pigs for aneuploid screen. We use them as guinea pigs for other interventions, for tests that are unnecessary. And they paid the price, and some of them paid embryos. Should we continue to do so or ask for validation? Otherwise, patients will be having that exploitation, which comes in too many forms. So as far as this debate or so-called debate is concerned, for AI, whether it will or it will not play a major role in our field, the answer is resounding yes. How can it not be? When Professor Abougar made the case very eloquently. But all that we need to do is to be cautious and proceed with caution. Because to push the boundaries, you need to know where the edges are. Otherwise, we will keep repeating the same mistake. I'm very grateful for your attention.